Welcome to the latest episode of Lateral Think, brought to you by Melbourne Athletic Development. Melbourne Athletic Development is a sports and injury management clinic based in Melbourne, Australia. To maximise your performance, optimise your injury management, contact the team at Melbourne Athletic Development. As many of you know, Jack and I have a very diverse understanding across multiple areas of practice, whether they relate to sports performance, say for instance with my background in track coaching, or with Jack and his background in yoga practice. We've combined a lot of this knowledge over time with our clinical and sports performance experiences to really develop what we do. And as you know, we love education. So what we've tried to do is take that knowledge and put it into an online learning community. We think this is important because it's an opportunity for people to interact, learn, and upskill as they try to improve the practice of what they do. So if this is something that you would be interested in doing, head to melbourneathleticdevelopment.com.au/education and get an understanding of how you can upskill your current practice. Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Jack?
How are you, John?
Very good, mate. So today we wanted to talk about what happens or what do you do when the outcomes that you're getting with a patient are not going as planned.
Yeah, I think a good topic of discussion, because it's always very easy to validate or justify doing things when things are working out as you expect. But the reality is you learn really what you know or what you don't know when things aren't working out. And it's good to think about, well, what actually leads to that and what do you actually do, or where do you start to think about, am I missing something? Do I need to change my direction? Is there some data, or is there something that I actually don't know that I actually need to learn?
Yeah, I think it's one of those things, as you said, we like confirmation bias, and it's always nice to obviously talk about successes. But I think as a practitioner, it is definitely a period of your development where you start to recognize, okay, these are my limitations. As you just mentioned, what do I need to go and learn? And what do I need to do if it's happening in real time?
Yeah, and I think we need to remember too that there are lots of different professions out there who use different techniques, interventions, and clearly you can skin a cat in many ways, so to speak. Health can be sustained on many different levels in many different ways. And the reality too is if someone presents with, say, low back pain, just with time itself, they're going to get better. So we need to be very cautious of always assuming that just because we're doing something that we believe in, that one, that's leading to the positive outcome, because it might just be an association, not causation. And hence why I think it's actually really valuable to think of more being critical when things aren't working out, to see like, well, what's going on here? Is this a limitation of my knowledge? Is this got to do with maybe a misdiagnosis? And more importantly, what am I actually going to do to actually make sure I get a good outcome with this patient?
Yeah. So in preparation for this, we sort of thought about some ways in which we can explore this. And in an upcoming podcast, we're going to try and use some of these ideas that we discuss here in a more specific case study.
Yes.
And it's not to say that we won't bring up some of those examples now, but we want to kind of talk about the principles associated with maybe what you would do in a situation where it's not working out how you would like.
Yeah, and I think this is where, something that I think we have been critical of is it's certainly much easier to think of like, okay, this person's got this particular injury, I'm going to follow this particular protocol. And, maybe on average you get a good outcome because that person probably was going to get a good outcome regardless. But again, this comes back to, well, if things aren't working out the way you expect, you need to ask yourself, well, what is missing? For us, we really use a framework to be able to make it more objective to see, have we actually covered what we consider to be the main domains associated with musculoskeletal injury or disorders? Yeah,
and I think like one of the things that we mention a framework to people, and I think we've discussed this at length at different times, but the three main areas that we always discuss as what we believe are the key domains, as you mentioned, because obviously these domains are very broad and they encompass, we hope, most of the areas that can influence, but are related to biomechanical capabilities and sensory motor capabilities, function associated with tissue properties, including factors associated with the capacity, but also the quality of the tissue.
Yes.
And the other major one which we talk about a lot, is hormetic load, and people sometimes aren't sure what that means, but basically what's your ability to deal with stresses, whether they be physical or non-physical. And obviously that's a combination and a confluence of your previous exposure to stress, in those different areas.
Yeah, and look, I think this is actually quite well captured when you look at the literature, for instance, with, let's say, like soft tissue injuries, a very common sports-related injury, where clearly there's been a lot of research looking at, is this particular variable, like strength, related to an increased prevalence of hamstring injuries, or fascicle length, or flexibility, and the list goes on and on and on. And clearly there are some indications that certain variables have a stronger signal associated with injury than others. But I find it interesting to look at some of the other research. I think of that author Mendegucha, who's done some research in hamstring strain injuries where they actually do a whole set of different variables associated with like things like changing running mechanics, thinking about different developing tissue capacity to enhance those particular biomechanical
in particular,
results.
obviously, that they did a study that I thought was great. They initially sort of validated in walking, and it was about pelvis position. And they're obviously looking for reducing hamstring injury strain risk, and what effect that changing pelvis position would have on that. And then they put in some sort of intervention studies looking at retraining those factors and seeing what effect it had on the biomechanics in both walking and then in running tasks.
Yeah, and look, that to me highlights a couple of interesting things. Like, one, it may get criticised because they're doing multiple interventions at once, but the reality is that's what's reflective of what you do in the real world.
Community,
But also it highlights too that two things. One, by addressing multiple things at one time, you're going to get some interaction of those things that may potentially lead to a better outcome. But more importantly, it's highlighting, well, we know that there are potentially multiple factors associated with the particular pattern or injury that we're seeing. And that's something that I think we need to always remember with what we do clinically, of like, what data do we need to collect, and then how do we actually interpret that into terms of what we do?
Well, I think this leads into, you set up some questions for this, and it's the first one, like, if we do have that approach, how do we actually know that what we're doing is the reason that person is getting better or even worse?
Well, look, I think it's always important to remember that things are correlated. And I think what we need to remember too, working with people, is we're trying to see what patterns emerge from the things that you do. I think we need to be cautious of not being too overconfident, that assuming that it's only because of what we do that's leading to the outcome. But at the same time too, we need to just follow what actual changes are occurring. So as you apply interventions, are you seeing the changes that you expect to see based on the data you've collected, based on the deficits you identify that you hypothesize to be associated with why they had that injury, within a time frame that fits the underlying pathology?
And I think that that's like one of the key things that, we've spoken about this before, but is changing your mindset slightly from being input focused to being output focused. Like, what results are you getting, right? It's often very difficult, as you mentioned, to be able to determine specifically which input was the major driver for that change, because obviously those factors, once actually applied to a person, are going to interact in different ways. And as a silly example, if, for instance, someone has, if we continue, say, with this hamstring strain injury risk, if someone's coming in with a lesser training history related to hamstring strain, applying some sort of eccentric loading pattern may actually cause a significant amount of muscle soreness following that intervention, irrespective of the injury that's present or not present, as opposed to someone who's been exposed to a lot of that type of training or that type of hamstring loading, and for that reason they're going to actually not pull up sore at all and not have DOMs. And the outcome that you're getting is going to give you more information than the input, because the input was exactly the same. Maybe you did 2 sets of 6 Nordic hamstring exercise, lowers or something like that. So it's like, was it the thing that went in, or was it the thing that came out that gave you more information? And it's probably the thing that came out.
Well, and the output, and then ultimately the outcome too, because again, keeping things in a more simplistic fashion, if someone does have a particular, you identify that they have a strength deficit, or maybe they don't, you think that they need to do strength work, but then they sustain another soft tissue injury, well, clearly the intervention that you're applying isn't appropriate.
Yeah.
And like, I know that can sometimes seem like an obvious thing, but I often think that people overlook that. And this comes back to starting at data collection, because I think we need to make sure that once we have a clear indication of the diagnosis, that framework of how you or what you do clinically changes from what the injury is to why have they got it. And this is where I think using a framework will keep you honest, because you can always go back to a framework to go,
have I assessed these things?
What are the modulators? And, the reality is that can potentially be very broad. And sometimes, and we have this experience ourselves where something isn't working out and you go back to the framework and you go, oh, I actually did miss that. And lo and behold, you go to assess and you go, right, okay, there is quite a deficit in that. And
the question that I have then is, okay, and I think that, we gather this through a clinical experience, but how do you start to actually formulate which things are the things to measure, which are the KPIs versus, it's like those, need to assess or need, nice to have versus need to have sort of assessments.
Yeah, look, I think
that's a challenge.
It is. I think one place to start that you mentioned before is looking at the training history, and we associated with that the maturation of the system. Because for someone who, for instance, is a younger athlete who doesn't have much training history, there are probably some more fundamental or foundational elements that you need to develop. Like a good example of that is something like strength. I mean, it seems to be sometimes the only thing that people will focus on, but for someone who doesn't have much experience or development in the gym, that actually may be a really fundamental thing that they need to actually develop. I think what's also really important is, even if you're not necessarily able to capture lots of data of each particular domain, it's good to try and capture a little bit from each one, because that also gives you...
More the question that I have is, how do we know that what we're measuring is actually the important factor? Like at the moment, I think it's one of the challenges that you have, and I'm not posing that I have an answer. I don't. Like for instance, with hamstring strain injury, if we stick with that example, I think that we're more lost now that we've had the hamstring injury group come along and try and tell everyone what to do. We're getting actually worse outcomes if you look at the data in professional sport, right? And then they try and argue that it's because people are not compliant with doing Nordics. Now, there are factions of that, but it doesn't seem to be appreciably changing the risk to the level that you would hope, given that their data is so robust, right? And I'm not saying that their data isn't. I'm not trying to be critical in that sense. What I'm saying is it's clearly not the only factor that's contributing. And I openly had a conversation with David Opark, I don't know, a long time ago now, where he said, like, obviously there's multiple factors that go in. We know that eccentric strength is one of them. We see it as sort of like it's a cliff. And the more of these factors that you've addressed, the further you get away from the edge of that cliff, right? And I think that's a really appropriate way of looking at it.
Yeah, absolutely.
However, measuring maximal force output in the hamstring in different ranges or whatever doesn't seem to be the one thing that stops you from getting a hamstring strain injury, even though the data suggests that it does actually reduce it. So I think one of the things that's really challenging when things are not working is trying to understand how even the factors that are well correlated seem to interact with each other, and also knowing which ones to measure and place importance on in a particular individual.
Yeah, and look, even just from a research perspective, I think of Brady Green and Tanya Pizzari's systematic review of looking at isokinetic testing for hamstrings, and the correlation isn't as strong as you think. No. Just because there's a couple of papers that show it, there's actually plenty of papers that also don't have agreement with that. And again, I think this highlights something that we talk about a lot, and I'm always cognizant of, hopefully we don't lose people's attention when we do this, but understanding complexity and understanding that we actually see it in the data where you see variability in the outcome within a single study anyway, when you look at the variability of results, because we're only capturing the average, we're not capturing the range. But then when you look at the larger body of evidence, I mean, there's a reason why so many systematic reviews come back inconclusive, because the reality is we don't necessarily see that consistency time and again with regards to this variable. We know that regardless of you do nothing else, if you address that, you're always going to see a reduction in injury. In fact, when you think about it, I'm not sure if there's any particular systematic review that's come to that conclusion with regards to musculoskeletal injury.
No, they generally are more broad. It's like we know that exposure to strength training reduces injury risk overall for, say, muscle strain injuries. But it's not specific to one exercise.
Yeah.
And I think that's a hard one because, when things aren't working out how you want them to work out, you want to be able to pin it on, I did this assessment and it told me this, and therefore if we, work on this. But I do think it's one of those things of, as I mentioned, with David Opar, working out which factors are going to push you further away from the edge of that cliff.
Yeah, absolutely. And this is where I think you need to think much more on a case-by-case basis. I mean, there are obviously, there are certainly general principles that you can apply, but I think of another example of thinking of, say, like biomechanics with tendinopathy. And we actually spoke about this briefly with Richard Newshenworth last week off camera, where if you look at the data for biomechanics, like associated biomechanics for developing tendon pain, again, it's a real mixed bag. And a lot of people, particularly tendon researchers, will say we don't need to worry so much about tendon biomechanics because the evidence is inconclusive. And it's like, well, there actually are studies that show that it is relevant. So I think that part of this is also thinking about, if we're seeing mixed results, do we need to just take a step back and just think about, if we see someone who has poor running pattern, and use, like, again, this example of tendinopathy at the Achilles, and we see that they have poor mechanics around active stiffness of their ankle, is that something that seems plausible to potentially overload their tendon and make it become symptomatic and pathological? And I'm probably of the opinion to be like, yes, I would think that is somewhat relevant. And I think more importantly, even from that, you create a hypothesis of like, okay, I see that this person's mechanics are associated with overstriding if you think about hamstring strain injuries or having poor ankle stiffness with Achilles tendinopathy. What happens if I implement interventions to change that? And this comes back to setting up, like what we've talked about before, safe to fail experiments, because that in itself gives information to you very quickly about whether you're seeing changes in their symptoms that leads to better outcomes over time. And this in itself is a pretty simple principle. I don't think this is necessarily groundbreaking in the sense of how we think about it, but I think it's important to bring it back to the individual as opposed to thinking like, but the literature doesn't necessarily show that. And that in itself, I think, is something that we always need to be cognizant of when we think about using research in clinical practice, is it helps us to give us signals of what may or may not work. And when we start to look more at the larger body of literature, we can start to think about what are all the potential variables. And that's obviously, for you and I, that's where the foundation of the framework we use at least comes from, of thinking of what are the modifiable factors we know that are associated with musculoskeletal injuries.
Well, with that in mind, like what steps are you consistently taking to make sure that you're not missing things? Is it as simple as just referring back to a framework, or do you think that you need to go out and maybe reach out to certain people? You need to explore other factors in relation to research. How do you think you go about that process? Like if it happens to you, which it happens to both of us relatively often, like what do you think are some of the real practical steps that people can take?
Yeah, look, I actually think one really simple one too to remember is, do you have are you collecting data from all those different variables, and do you have the ability to collect that data? I think the other actually really valuable one that I know we use is, do you actually have a team that you can actually bounce ideas off? Yeah, or someone actually. That's
even just to talk through your thinking. They might confirm already what you're thinking, and they might go, yeah, you're on the right track. But I think it's often useful to at least explain what you're doing.
Yep.
Because it brings up their opportunity to bring forward ideas. And I guess this kind of like comes into the concept of, at least in a professional setting, of having like, mentoring or, feedback systems. And I think those are valuable kind of structures to be able to call upon when you're not necessarily sure what's going on. Do you think that that's something that if you don't have, you can actually seek out in other ways?
I think one, it's something that's absolutely imperative. I think also too, and again, we talked a little bit about this with Richard last week, is it seems to me that the people who stay in the profession long terms are the ones that take that approach. Because I think one of the most important things to remember is there are things that you don't know. It's like those unknowns, but it's a matter of, do you have systems in place to potentially shine light on those things that you don't know?
Do you think that's part of like your sort of professional maturation, in the sense that early on, I think people are less likely to ask for feedback or are less likely to seek out help because they're probably a little bit, unconfident in their perception of what someone will say or think if they come asking for help?
It's funny you say that. You made me think of the first clinic I worked at. I talked to my boss saying, do you mind coming in and watching me with a patient? And he said, like, oh, look, I'm happy to do that, but would you find that too confrontational? I said, well, like, not really. Like, I mean, the best way to see whether I'm full of shit or not is for someone else to actually watch me and go like, oh, okay, what about this? You didn't look at that. Why'd you do that? And it was funny because I said, maybe actually you end up doing that for all your employees. He's like, oh, honestly, I don't think actually a lot of people would feel comfortable doing that. And I found that quite interesting in itself, because I understand that it is actually quite a confrontational thing to actually be watched by someone else. But at the same time too, I also look at it as like, well, why are you here? Are you actually not interested? Are you interested in actually
getting better?
And what's a better way to do that than actually someone watching you? Or the other one potentially too is actually recording yourself and actually watching it yourself to see whether what you think you're doing is actually what you actually see when you record it and actually review it. But look, I think one of the things is, and I'm always a little bit skeptical or at least apprehensive of people who are too absolute in their opinions about how to, treat a particular injury, is you always need to leave room for the fact that...
room for growth, really.
For growth, and also for not making the assumption that just because two people present with a similar injury, that the management plan is going to be the same for both too.
I think one of the things that is nicer as time goes on and you develop more of a professional network is the ability to reach out to people that have greater expertise in certain areas compared to yourself. And so when you see a presentation, you actually very much understand like, oh, okay, I'm going to call this person in, whether it's within your own setting or another setting, to give me an opinion on what's going on. Yeah. And interestingly, and this is, I think, been one of the more enjoyable experiences with that, is that I feel like patients actually quite appreciate you saying, oh, I have a colleague, they specialize in this, or, I'm elevating this up, say whether it's a surgical opinion or I want you to see like a medical opinion. They actually quite appreciate that, rather than you saying, no, we're just going to stick with this, even though they themselves are reporting that there's not improvement happening in, say, their symptoms.
Yeah, absolutely. Well, I think the worst situation you can find yourself in is if someone isn't progressing the way that you would expect them to, and you keep doing the same thing. Isn't that the definition of insanity? But absolutely. And look, we've talked about this before, where nowadays, like I know for instance, when I listen to podcasts or read a book, the things that I find most interesting are when you listen to something and you go, I actually have no idea, or I've never heard about that particular concept or that area of knowledge before. Because that's when I think you start to really spark new ways of thinking. When
you start trying to draw connections between that and what you do know.
Look, absolutely, and that's where I think it's really interesting and important is, it's one thing to listen to another podcast of someone saying, oh yeah, you just got to strengthen the hamstring more. And it's like, look, maybe, and I'm not saying that that's not relevant. It's absolutely a valuable thing. But it's more of when you actually come across data or research where you're like, oh wow, I didn't really think of that as a variable associated with musculoskeletal injury. It's actually, we're just talking about this before the podcast, of a weekly presentation I did this week of looking at the area of what's called nutrigenomics, which is looking at how nutrition influences genetics. And there's some interesting research that's been published just recently of looking at certain genetic polymorphisms associated with an increased prevalence of hypermobility, and people, in particular people who are who have hypermobility, are symptomatic, and how that certain nutritional strategies to be able to positively regulate those genes that influences connective tissue laydown may be a really key factor for treating people with hypermobility. And like we were talking about, well, the idea of hypermobility is a spectrum where there's obviously some people who are very hypermobile, and particularly if you're sedentary, might have sort of chronic polymyalgia. But then we're talking about with athletes that we see who have that hypermobility spectrum and maybe more predisposed to getting things like tendon pain, how potentially you could be using nutrition to be able to influence the regulation of their genes that leads to better, stronger laydown of collagen. And like that to me was so fascinating, because it's like, I've never even thought of that. Yeah. And just thinking of, again, sure, we've talked about nutrition and we certainly really value how nutrition is important, but the idea of nutrition regulating genes that influences musculoskeletal injury, that was sort of a thing of like, wow, this is a completely new area for me that I haven't really considered.
Well, I think that opens up that idea of like, how do you know what you don't know? And I think that's a really difficult situation, and it was popularized, and it was developed. That kind of framework was popularized by Donald Rumsfeld when he did that speech talking about known unknowns, and people thought he'd lost his mind. But actually, there's a couple of psychologists that developed, it's called a Johari, it's their two names put together, Johari framework or whatever it is, and it's like known knowns, known
unknowns, unknown knowns, unknown unknowns, yeah.
And I think that's a real challenge of like, something like that comes along and you've been dealing with someone who's had these presentations consistently, and you're managing those things relatively well, but you kind of keep scratching your head and like, why does this keep happening? We seem to be ticking off all the major areas that influence, based on even maybe the framework that we've used. Do you think that there is a time and there is a way to actually address that kind of process where you get stuck and you're like, it's not that I'm not managing this to a certain level, but it's just not quite adding up?
Look, absolutely. And part of it's a mindset of the clinician. Do you actually have that mindset of you like are curious, you actually want to continue to learn and develop that? Because like I just know for clinicians I know, or even researchers I know who have been doing it for 20, 30, 40 years, that mindset hasn't changed. I think of someone like Yui Prosk, who we had on, who is now retired and an emeritus professor, but actually still does research. And part of that is because he clearly has a curiosity.
Interested.
Yeah. But I think also, and it sort of comes back to my point, I'm actually always very cautious towards people who are very absolute in terms of how you manage.
That's a polite way of saying it.
Yeah, how you manage injuries, of assuming that, well, we know all and there's nothing more to learn. It's like, that's not reflective of the scientific process, which it is itself a process. But I think the challenging thing that we have though at the moment is thinking of how you use research to direct what you do clinically. Because I think one of the issues we currently have is you look at the conclusion and it goes, well, this wasn't effective and therefore you dismiss it. Or this was effective and therefore that's the only thing that you need to do. And so if you don't, I don't know, it's one of those things where unless you're actually questioning yourself frequently, you can often get stuck in that assumption that you've got everything figured out for that person and that it's going to have a good outcome.
Again, I think it comes back to what we spoke about before of like the output and the outcome, and like, are those things meeting the expectation? Even if they're traveling in the right direction. Like I always think about what's the ideal situation.
Yeah.
Like the ideal situation, say for someone who presents with a musculoskeletal injury, is that they have no pain and their function level is extremely high or exceeding the requirements for what they do.
And they have no future injuries.
So unless you're anywhere near that, there's probably always something to explore.
Yeah. I think the other one too, and I'm sure you can touch more on this yourself because you're a coach and you've worked with the same athletes over time, is what was appropriate for them when you first started working with them is not appropriate for what was for the next season, which was not appropriate for what you do with them now, because of the fact that you see their system is dynamic in nature. And I think that's the other problem that people often get stuck with, is going, well, I've had using this particular protocol or focusing purely on strength or running mechanics, whatever it is, that mitigates injury because I've seen that before, assuming that that's going to have the same effect in the future. Now, it's not to say that if you've seen those particular patterns that they may be really big modulators or levers that you pull. It's the assumption that that's always going to have the same outcome, because I think this is where it's important to think about what you see on average versus what you see with the individual in front of you. And until you make that distinction, there's always, well, not always, you'll eventually get caught out in the sense of, okay, I'm not seeing this work as I expected, but my previous experience has shown me that that always leads to good outcomes. What has actually changed?
Yeah, I feel like this idea. I've got an example which I'll use, which is related to running mechanics, but I feel like it's like this idea of almost like a dynamic equilibria. It's like each time you go up in a level, it stabilizes at a certain point again, and you've got to work out whether that new equilibrium point is actually sufficient for the task that they're undertaking.
Yep.
You know, especially in sport, it's one of those things where, you know, like you obviously want ongoing progression. It would be ideal for athletes that they always get better at their sport. You know, whether that's a skill, whether that's a physical output, whether that's a mental approach, whatever it is, the idea is that they should continuously get better. And I think it's one of the attitudes that probably helps us working with more athletes is I think we take that same mentality when it actually occurs with people in the general populace, because we don't allow them to accept an okay or a moderate or a so-called normal level of populational health. You know, so, I can lift this 10 kilo box. And it's like, well, you're capable of lifting a 50 kilo box. So why are we stopping at 10 kilos? Like, yes, you don't typically lift anything that's more than 10 kilos, but now that you're capable of it and you can do it pain-free and you can do it overhead, maybe we keep going. The example I've given, and not that it's particularly relevant to this discussion, but I've had this conversation back and forth a couple of times with some of the staff at the VIS about like stride length and stride frequency and how they typically are.
I'll quickly turn that heater off. You can just hear it's picking up.
Sorry about that. So as I suggested, I have had this conversation a few times back and forth with some of the VIS staff. And one of the things that we spoke about is that sort of equilibrium and that balance that you get between stride length and stride frequency for maximal velocity, or the velocity that you're trying to hit. And it's always a balance. Like you might cue for a period of time, like I need you to actually be trying to project more and increase your stride length and the propulsion that you're creating. But obviously that comes at the cost of the stride frequency that you're generating. And your job is slowly to catch those two things up. And then once they reach a sort of equilibrium that you're happy with, that's now an improved level of performance, you've got to start that process again. And it's never a thing of like, should you cue stride frequency or should you cue stride length? Because they work in harmony together. And so if you over cue one and the adaptation over time is that one becomes so dominant that the other one's being left behind, you end up in this position where you have lost capability. So it's always this thing of you're constantly trying to level up each of those features to a higher position. Now, some of those might cap out. And so then you've got to make a decision, is that adequate or do I need to actually put in some sort of higher magnitude intervention?
Yeah.
But I think it's a similar process that you go through when someone reaches a level of capability. You've got to consistently be thinking, okay, is this level of capability reasonable for the task they're doing? And can I keep extending them beyond this?
Yep.
Because, for instance, in the general populace, it's like they will have better outcomes in terms of their day-to-day life, their general health, and their capability with long-term musculoskeletal function if they continue to actually progress some of those features.
And actually, just using that example of stride length and frequency, correct me if I'm wrong, but I also imagine too that thinking of the dynamic nature of what you focus on, if like, for instance, that off-season you work on building up tissue capacity because you've noticed that their power's down through their lower limb or they need to work on their elastic function, you work on that. You may then start to see a new pattern form where for instance, they can achieve that stride length much more effectively because they're more powerful. So then you can actually focus more on, say, for instance, stride frequency to actually build that up. So like even from, season to season, as you start to see their system mature because you focus on developing other capacities, it changes what you can focus on biomechanically? Or is that...
Yeah, no, you can see, I'm sure, me thinking. I have been questioning this a lot. This is completely aside, but you know what we like tangents. I've been thinking about this a lot, actually, because I think one of the biggest problems that we see in the utilization of biomechanical items, especially associated with tissue capacities, is that people think that there's a transfer that occurs without the actual coaching of that skill. And we've spoken about this before, but in order for that transfer to occur, I think that the skill execution has to be coached at a really, really specific level. Because if you don't do that, you actually often don't get the transfer, even if they have, say, the power dynamics or the underlying tissue capacities. So, like, sometimes that does happen where someone, like, particularly through physical maturation, you get someone like a young kid, they start doing gym at 16, 17 years of age, they get a hell of a lot more power, they get stronger, and then all of a sudden those things do naturally happen and they naturally know how to use them. But often I actually think that you have to coax those things out by exposing them to very specific tasks. And I think that's been a bit of not a failure point, but like a recognition that, okay, I need to get even more specific. If I want to see a certain biomechanical output, I've got to try and design training elements that really actually ask them to specifically do that task. And like the prime example I would give is, say, if you're trying to develop stride length, create opportunities for them to do things like, whether it's wicket runs, where you're actually specifically asking them to cover a certain distance consistently. Right, like just because they are capable of doing it in one effort maybe, or that's what they do in, say, a competition setting, in order to develop that feature, you actually need to spend time there consistently. And interestingly, with the amount of development I've seen using some of that stuff, it's not related to changes in, say, their physical capacity in relation to, say, power or elastic function. What that suggests to me is that they have like dormant capacity that's sitting there that's being underutilized. So if you want to get that out of them, you better actually expose them to that.
Well, actually, I think though too, like bringing it back to the topic of this conversation, what it really highlights though too is the benefit of experience. When you get to work with a certain population group, you start to see what are the particular patterns or like key modulators associated with performance or injury prevention.
I think that's one of the... Sorry.
No, it's right. Go.
I think that's one of the things, like we've spoken about this before.
Yeah.
And I remember we brought it up actually with Richard in the first talk we did with him. And we kind of agreed to disagree. But I think that it makes a huge difference if you've been involved in, say, that activity.
Yeah.
Now, it might be a workplace as like an occupational, physio or occupational therapist. It might be, like as a, say, a medical professional on a military base or something like that. But like understanding the context, understanding the environment, understanding the physical, say, requirements or psychological requirements, I think is actually very vital.
Look, I even think of that too, of if you work in a particular sport, like let's say, for instance, you work in soccer, but you're not a soccer player yourself and you can't kick a ball, that actually limits your ability to do effective rehab out on the field.
Totally. And whilst it doesn't stop you from developing those skills, I think that there is a huge advantage that you have. And we spoke about this, like my sort of position on this, I don't think it's changed that much, is that you need to have participated at a reasonably high level.
Yeah.
Now, I'm not saying you need to have made it as a professional or, whatever, but like you actually need to have participated at some reasonable level to understand what that task is about and to understand the stresses of that task and being in an environment that is at least somewhat closely related.
Yeah. One other thing I was going to mention before, and the question you asked early on in this podcast was, like, what do you know what to work on? I think, and one of the big things, and I mentioned this briefly, but it's worth discussing more, is maturation. Because if you're working, for instance, with a youth athlete, the reality is you could do a lot of different things with them and see a positive improvement.
Yeah.
And it's funny, like we've had this conversation before with people that we know who work in adolescent development, and they assume that what they do is gold because they've seen improvements in their outcomes. It's like, to be honest, you could have done so many different things and led to a good outcome. And I think that's actually a good thing to think about with the general population too, where someone comes in with back pain and you could just focus on manual therapy, or you might focus on just flexibility, or you might just focus on doing strength training. And if they're someone who's sedentary, who hasn't done anything before,
their system is ready for application of some intervention or stress.
Totally.
So it's going to, if whatever you've applied is applied appropriately, the likelihood and the probability is you will get a positive outcome.
Yeah.
It's not to do with the fact that you chose the perfect intervention.
And that's why I think you always need to be at least open to critiquing, and not just whether someone's having a good outcome, but are you actually optimizing that? Like, this comes back to something you mentioned before of, are they improving at a rate at which you would expect?
Yeah, that's a really good point that you make.
And also, like, is there anything that you're missing out? Is there anything that you're leaving on the table? Because it's all good to work, for someone to come in, next week by week and go, oh yeah, no, it's getting better. You're like, yeah, great, I'm doing my job, I'm fantastic, I've done everything
and that's where things like outcome measures are vital, because you can actually look at that and go, well, they've improved 1 point in the pain of this task over the course of 6 weeks.
Yeah.
Whilst that may be meaningful to them, that's probably, as you as a practitioner understanding the rate of change and even, margins of error in relation to system, like the error in the actual measurement itself, it may not actually be significant and clinically significant. So it's important that you have some of those objectives. That's why you said collecting the data, even if it is subjective data, that is recorded and actually done in a way in which you can keep that, objective enough to reassess. Yes.
And is there something that I'm missing that can further enhance the rate of change? Because I think that's the other big one too. And that might be something as simple as someone presents with a soft tissue injury and you think it's some type of intramuscular or very myofascial type injury where it's relatively low grade and you'd expect them to get better within a short period of time. Do they meet the timeline that you expect? And this is what you need to also open up into thinking of, not just the actual interventions you use from an exercise rehab perspective, but then I guess also thinking about some of the hormetic factors too associated with how is this person healing within an appropriate time frame as well. And so it's always useful to think about, am I capturing all that information?
Yeah. Before, when you mentioned, I remember you asked me about this actually not that long ago. And I think it's always an interesting kind of game. I don't know, I always bring it back to the coaching stuff, but like seeing the progression of people across, say, different time periods and understanding that sometimes those interventions see massive improvement. And it's very obvious to me, based on what you were saying before, that like some people are much more receptive at different time points to accepting that kind of input.
Absolutely.
Like often the programming that I do, although it's individualized, it's very similar for certain populations and event groups, yet you might see very, very different outcomes. And that can often be associated with, well, for that person, that intervention was appropriately applied to the level of stress that they actually required at that time, and then all were able to accept and grow from. And for another, it's not that they have potentially performed poorly, but maybe they haven't seen growth because that was actually pitched almost too low, or it wasn't specific enough to create the changes that you needed because that person actually has been exposed to much more stimulus of training in the past.
Yeah, the actual magnitude of the stresses they need is much larger than what you would typically expect.
And I think that that's something, as I said, like we mentioned before, it's like that equilibria goes up. I've noticed that a lot where once someone goes to a certain performance level, which is higher, you actually need to keep upgrading those features. And I don't know that that's always discussed.
Well, actually, that's a good question to consider. I'm interested in your point is, do you think it's easier to treat someone with an injury who, let's say, is not an elite athlete, who has minimal training history?
Yes.
Or the other end of the spectrum, someone who's actually a really well-developed athlete, they've got several years of training and developed lots of capacity.
It's that age-old question, and that I'm quoting this to probably incorrectly, but I'm pretty sure it's something like which is easier to improve, a tractor or a pencil. It's pretty obvious which one's easier to improve. Yeah. Even though the pencil's really simple, improving the design of a pencil's pretty difficult.
Yeah.
Right? Whereas with a tractor, and it is opposite in some ways because obviously someone who has more features developed actually has more complexity. But if they've got lots of the features already sorted out, like the pencil, it's like, what do you work on? It's actually part of the reason why I enjoy the challenge of coaching sprints, because it is a very simple task. Like, go from here to there as quickly as possible.
And it's timed, yeah, exactly.
Right? It's not that difficult, and there's not that many moving parts. So, there's lots of moving parts at a certain point, but the challenge to it is that it is a very simplistic, ergonomic task when you put it down to describing it. Whereas if you compare it to, say, a basketball match,
field sports or ball sports,
there's so many things to do
that
you could work on lots of different things and get an improvement.
Well, and I think the great example of that, and it's actually not to dismiss any individual, but let's say you always hear of people who do a PhD in one particular area, they then move into clinical work, whether it's like an S&C or physio with a team sport, and they're like, well, this is my particular baby because this is what I've done research on, this is what you've employed me for, we're just going to focus on this. And you always associate that because you focus on that, that's what led to the better outcome, if assuming they have a better outcome of the team's performance, not taking into consideration that the reality is you've actually developed so many different things, and whether your thing was just an interesting or fortunate correlation to that success, or whether it actually had a large influence to changing the performance of the group or the individual, is questionable.
I think that's, and this feeds into this, I think it's about having the professional humility too, to understand that what you're doing probably plays a small part. Now, it might be an integral part, but it's a small part. And whether that be, as you said, as a support staff member, or in the community, sometimes people get better for lots of different reasons, and some of them are not related to maybe the intervention. We've spoken a lot about the psychology of injury and the presentation of health and how that changes. And so potentially someone has maybe made some life decisions or changed their approach even psychologically to what their health means to them. And that's the reason they get better, not because you necessarily picked the most appropriate intervention. You might have picked an appropriate intervention, but it's not magic. It's not the only way to approach it.
Yeah, and look, you need to apply that same principle to yourself if you're a health professional or a coach, because I always laugh when we have students or new grads, when you talk to them about non-physical factors associated with musculoskeletal injury. And I think a lot of the time, and to be honest, I was the same myself when I was at uni, when someone talks about how psychological stress or beliefs influences someone's presentation, you're like, I'm putting that aside. I want to know about all the mechanical elements associated with this injury.
I think that's so funny because I think we're all the same. And maybe it's a guy thing as well. But I remember that, the biopsychosocial. I was just
shut up.
That doesn't mean anything. Stop wasting my time with this, woo-woo crap. This is not important. I don't care about what someone thinks. It's just about working out, the biomechanical inputs and then fixing those things, and that's it.
Well, and look, I know for me personally, when I actually learnt about the underlying mechanisms and what's happening at a molecular level, you start to realize that biomechanics, people forget about the biological aspect and how tissue environment influences the actual behavior of the tissue, but then its response to mechanical load. Once you start to do that, you're like, okay, there's that light bulb moment of going, this is actually why it's relevant, because the fact that you're getting poor sleep is actually influencing your hormonal inflammatory state, which at a tissue level influences the actual behavior of the tissue and how it responds to mechanical load over time. But and that, this sort of comes back to understanding principles, because the more you understand the principles, the more things you can consider that are potentially relevant to that presentation, and then actually start to think of, well, maybe actually the biggest factor here isn't a mechanical factor. Maybe there are some non-physical stresses that are exacerbating this person's presentation because they have peripheral or central sensitization because of the fact that they are in a non-healthy state.
As you're saying that, I'm thinking, like, how do we summarize this? Because we've jumped all over the place for people.
That's not like us.
and you can tell how we don't necessarily come at these with the idea of trying to force down any sort of particular thing. So if this is itself all over the place, we apologize. But I think we've kind of come to some of those, you said some key principles. I think we've kind of come to some of those and they're pretty obvious. The key ones seem to be, continue to question yourself all the time and ask questions about where you're headed and is that timeline, as you said, reasonable or ideal for what you expect.
A really simple question to ask yourself and start is, what's your actual philosophy or framework for how you actually approach treating people?
Well, I think that's too broad, mate.
Well, I mean, it may be, but I think...
Well, I think the question is like, do you have a framework?
Do you have a framework? Because, I'm guilty of this myself. Initially, I adopted that model of how do I diagnose an injury, and then based on that, what protocol am I going to use? It was that very simplistic linear model. And
it gets you into trouble after time.
Well, when you start to realize this isn't working a lot of the time, that's when I started to become curious of like, well, do I need to change my philosophy of how I actually approach treating people? And that's when I started to think about, well, what frameworks are out there? And there are different frameworks out there. There's lots of different ones that have come about. And that it's actually a really good starting point, I think, and sometimes often overlooked of how do you actually think about the problem you're presented with? Do you actually think about it, or are you very much? No,
I don't.
Well, I think there's an issue of heuristics can be actually quite useful in some ways, particularly with diagnosis of potential specific management that they need. But then the framework that you need to use to
we do need to talk about that at some point.
Optimize outcomes,
decision making and heuristics, and I mentioned before the work of Gerd Gigerenzer and how he talks about making some of these decisions.
You're good at name dropping.
People might want to look at it.
No, you're always just good at remembering authors. I'm terrible.
Yeah. His book Risk Savvy is a good general read, but he's done some really good research even in like healthcare and medical decisions, which talks about these things and understanding things like bound rationality or bounded rationality, and understanding like you don't want to go on as you just sort of mentioned there, like you don't want to go on a fishing expedition. You're like, oh, well, I've got to go explore all these things, when you can just use a basic heuristic to actually say, okay, the 99% probability is it's this, so I'm not going to go looking at 15,000 research papers to identify that one case.
Oh, no, sure. And look, I think that's where we'll leave this for another time, but the decision-making process you use for, say, a diagnosis is probably going to be different for the actual management of that particular injury. But, going back to thinking about highlighting some of the key points for this, I think it's always useful to think about, am I potentially missing something? And what strategies do I have in place to ensure that that comes to my awareness? And I think a simple one is...
We said like having professional sort of mentors or having professional environment that you can reflect with people. But you can add another thing?
Look, I actually think, one thing I think is always useful is, even when you think about the research, there are some great reviews out there. I'm not talking about necessarily systematic reviews, but actually a lot of reviews,
like
narrative literature reviews, which I think provide really good prompts too to actually think about
like what to explore next.
Totally, and really good at sort of capturing, here are all the potential things associated with these types of injuries or problems.
Yeah, okay. So if we summarize that for people before we jump off, make sure you're consistently, especially if you're not getting the outcome you want, you're asking yourself, what am I missing here? Who can I speak to about this so that I can understand whether I am sort of reflecting on some of those things? Is there literature out there that potentially will point me in the right direction? Who are the other people that maybe I bring into this intervention? Whether it's medical, psychological, dietetics, whatever it may be.
Yeah.
And as you said, like making sure that you take those opportunities to consistently question and remain humble about the fact that we don't know everything. and we can actually, be vulnerable enough to go asking for help.
Look, absolutely, and actually, we've mentioned this a few times, but that can also mean reaching out to us. Like for people who listen to this, who actually want.
We don't have all the answers, by the way, but
far from it. But certainly, we're always interested with working with people. Actually, answering questions people may have, or sharing resources we may have. Whether we actually have the resources or information to direct you, we'll let you know if we do or we don't. But we're also happy to actually connect with people who listen to this and actually help where we can, because I think also through that process we learn a lot from that too.
Alrighty, thank you so much for joining us.